Hey guys, today we'll be talking about unsafe csom. This video might be a bit long, but I've covered almost all the important things that is related to unsafe csom, so do watch it till the end. Okay, so before we talk about unsafe csom, we'll talk about cholesteatoma. Okay, because cholesteatoma is the thing that makes csom unsafe, because cholesteatoma has the bone eroding properties and which can lead to erosion of the bone and then the complication that we see in unsafe CSM. Okay, because normally the infection is confined in the middle ear due to the bony margins. But if there is bone erosion and bony margins are not present, then the infection spreads to the other part of the temporal bone. Okay, so we say that you can just break the words. Okay, normally we say that you can just break the words and we can find the definition of the meaning, but here we can't do it, because if you look at the word cholesteatoma, it looks like it talks about cholesterol and something to do with tumor. Okay, so it is a tumor that has something to do with cholesterol, but it is nothing like that. It's a misnomer. Okay, it's a misnomer. Okay, so what is cholesteatoma? Cholesteatoma is the presence of stratified squamous keratinizing epithelium. Okay, stratified squamous keratinizing epithelium in the middle ear, and the mastoid. Okay, or we can say in any part of temporal bone, since the middle ear and the mastoid are a part of temporal bone. Okay, except for external auditory canal. Okay, if there is presence of stratified keratinizing epithelium in the temporal bone except for external auditory canal, it is known as cholesteatoma. Okay, so if you look at the structure of the cholesteatoma, you can see there is basically two main features that you can see. There is matrix and the keratin mass. Okay, so matrix is a stratified squamous epithelium, okay, which rests on a fibrous stroma, and matrix produces keratin mass. Okay, this is keratin mass. Okay, so this is the cholesteatoma. So as I said, cholesteatoma has this bone eroding properties. Now, how does cholesteatoma erode bone? Okay, now if there is cholesteatoma, there is macrophage activation and osteoclast recruitment and activation, and this macrophages and osteoclasts, they release certain enzymes like collagenase. Okay, like collagenase, acid phosphatase. Okay, acid phosphatase and proteolytic enzymes. Okay, now these enzymes, they cause bone erosion, and because of this bone erosion there can be a lot of complications that we see in unsafe CSM. And also because of this bone erosion, there is foul smelling discharge in unsafe CSM. Okay, just keep in mind. Now there are lots of theories which describe the origin of cholesteatoma. Okay, first one is there is presence of congenital cell rest in the middle ear. Now this one is specifically for the congenital variant of the cholesteatoma. Okay, now then second we have the Whitmark theory, which is the most commonly accepted theory. In this theory we say there is a retraction pocket in the pars placida or the thorax space, and there is accumulation of the keratin debris in the retraction pocket, and it perforates and we see cholesteatoma in the middle ear. Okay, and then we have the Rudy's theory of basal cell hyperplasia due to repeated infection of the tympanic membrane. Okay, and then we have Haberman's theory of migration of epithelium through the perforation, and usually a marginal perforation. We will talk about that with the secondary cholesteatoma. Okay, and then we have Sarday's theory, which basically revolves around metaplasia due to repeated infection of the middle ear mucosa. Okay, so classification of the cholesteatoma. Now, classification of the cholesteatoma can be divided into congenital and acquired. Okay, the congenital, it means there is a presence of embryonic epidermal cell rest in the middle ear itself, and it presents as a white mass with intact membrane. Okay, intact tympanic membrane, and there is no history of perforation. Now acquired, it can be secondary and primary. You have primary and secondary. Okay, now in the primary acquired cholesteatoma, there is migration of the epithelium from the external auditory canal into the middle ear without any tympanic membrane perforation. Okay, and in secondary cases, from the external auditory canal into the middle ear, secondary to a tympanic membrane perforation, and it is usually a marginal perforation. Okay, marginal perforation on the posterior superior aspect of the tympanic membrane. Okay, posterior superior aspect of the tympanic membrane, like this, posterior superior aspect of the tympanic membrane. Okay, this is the site. Okay, so now let's talk about primary cholesteatoma in a bit detail. Okay, now as you may have known by now, primary cholesteatoma has something to do with the Wittmaack theory, because it is one and the same. Okay, so what you see is normally there is no retraction pocket formed, okay, and the tympanic membrane is intact. Now when there is eustachian tube blockage, okay, eustachian occlusion and blockage for a long time, then there is persistent negative pressure in the middle ear, okay, persistent negative pressure in the middle ear, and there is retraction of the tympanic membrane, okay, tympanic membrane is retracted inwards. Okay, now normally if there is a small retraction and there is a small deposition of the keratin flakes, it is not big deal, because it will be cleared on its own. But since there is persistent negative pressure, okay, persistent negative middle ear pressure, and this retraction pocket gets deepened, there is accumulation of the keratin flakes furthermore, and it may be significant. Okay, so what we have to see is, with persistent negative pressure, tympanic membrane is retracted, retraction pockets are formed, keratin flakes accumulate, okay, and it deepens the retraction pocket. Okay, now these keratin flakes leads to inflammation, and due to inflammation there is macrophages activation and recruitment, and this phagocytose the keratin debris. But along with the keratin debris, it also phagocytose the normal epithelium, so endothelium, normal endothelium of the tympanic membrane. Okay, now since the endothelium is also phagocytosed, it leads to perforation and the keratin enters into the middle ear, okay, and it is the primary cholesteatoma. It leads to bone erosion and complications. Okay, then we have secondary cholesteatoma. Okay, now in secondary cholesteatoma, it is usually following a perforation, and the perforation most commonly a marginal perforation. Okay, marginal perforation in the posterior superior quadrant of the tympanic membrane. Okay, now in the marginal perforation, the fibrous layer is not present, and only two layers of the tympanic membrane are present, that is the epithelium and the endothelium. Okay, now epithelial layer grows inwards towards the middle ear, and along with that the keratin flakes also accumulates and goes inwards the middle ear. Okay, now there is recruitment of the macrophages due to inflammation. Okay, now again macrophage along with the phagocytosis of the keratin flakes, there is erosion of the normal endothelium as well. Okay, so see, this is the perforation, okay, and this epithelium goes inwards. So this epithelium goes inwards. Okay, now macrophages, they attack the keratin flakes. Okay, but along with the phagocytosis of the keratin flakes, it also phagocytoses the normal endothelium. Okay, which means the perforation is further widened. Okay, and this further widening of the perforation leads to further growing of the epithelium inwards. Okay, medially inwards towards the middle ear cleft. Okay, and then we see secondary cholesteatoma. Again, cholesteatoma are known to have bone eroding properties, okay, and it leads to complications. Okay, now that is all about cholesteatoma that you need to know. Now since you have known what is cholesteatoma, let's discuss unsafe csom. Okay, unsafe csom is also known as squamosal or atticoantral type of csom. Okay, now squamosal because of the stratified squamous keratinizing epithelium, and atticoantral because of the location. Okay, since it is usually located on the posterior superior aspect of the tympanic membrane, and just beneath that we can see there is otitis. Okay, there is attic here, otitis here, and then it is connected to the mastoid antrum. Okay, so since it is occupying this location, is known as atticoantral type. Okay, now as I discussed earlier, it is known as unsafe csom because it is associated with cholesteatoma, and cholesteatoma has the bone eroding properties, which leads to risk of serious complications. Okay, now what is the pathology of unsafe csom? Now unsafe csom is associated with the following pathologies. Okay, first one is damn sure it is cholesteatoma. Second one, there is granulation tissues present in the middle ear. Okay, and third, ossicular necrosis is very common in unsafe csom. Okay, hearing loss is greater in unsafe csom than in safe csom. Okay, and is usually a conductive hearing loss, but there may be sensorineural hearing loss or sensory hearing loss element as well. Okay, so ossicular necrosis is much more common in unsafe CSO. Now there is a thing called cholesteatoma here. Okay, now normally when there is ossicular necrosis, there is decrease in hearing and the patient doesn't hear well. But in some patients with unsafe CSM, they hear well with the ossicular necrosis because there is cholesteatoma that bridges the gap between the ossicular necrosis. Now suppose if this is the malleus, okay, this is the incus, okay, and this is stapes. Okay, just a rough diagram, don't go with the diagram please. Now if there is necrosis, like usually in the long process or the lenticular process of the incus, okay, cholesteatoma flakes come in here and they bridges the gap between the ossicular necrosis chain. Okay, and if the gaps are bridged, so the movement of the ossicles is intact and we get to see a better hearing in the patient with cholesteatoma. Okay, then there can also be cholesterol granulomas present. Okay, basically it is a foreign body granuloma or foreign body giant cell granuloma with cholesterol. Okay, so what are the symptoms that you see in a patient of unsafe CSO? Okay, first one, ear discharge. In contrast to the safe CSOM, there is scanty discharge, okay, and is purulent in nature and foul smelling due to bone erosion. Okay, remember that. Bone erosion. Okay, and then there is hearing loss for sure. It is mainly conductive hearing loss, but there can be an element of sensory hearing loss as well. And we can also see bleeding, which may occur from the granulations or the polyps. Okay, when you're doing surgery or even you are cleaning the middle ear, we can see bleeding due to the granulations and the polyps. Okay, now what are the signs? Okay, first one, perforations. In safe CSOM, we just discussed that perforations are always central. Okay, here the perforations are located in the attic or the posterior superior quadrant of the tympanic membrane. Is in marginal in type. Okay, because the annulus is also involved. Annulus is also perforated because and because of that there is no fibrous layer and it is easier for the epithelium to grow inward. Okay, now the retraction pocket, as we have discussed in the primary cholesteatoma, okay, there can be a degree of retraction pockets and it varies depending on the stage. Okay, so what are the stages of retraction pockets, or what are the stages of retraction of tympanic membrane? Okay, now this is Sarde's classification of retraction pockets. So at stage 1, there is tympanic membrane retraction, but is not in contact with the incus. So it is just a tympanic membrane retraction, but is not in contact with the incus. Okay, this is stage 1. In stage 2, there is retraction and the tympanic membrane comes in contact with the incus, like this. Okay, now you can see there's contact of the tympanic membrane with the incus. Okay, in stage 3, there is retraction and tympanic membrane contacts with the promontory. Okay, promontory, but it's not adherent. Okay, it's not like it is just sticking there. It is in contact with the promontory and there is no air in the middle ear. Okay, it is also known as atelectasis. Okay, atelectasis, we have also heard this term in the lungs. Okay, when the air is completely washed out. And in the stage 4, it is just like the stage 3, but now the tympanic membrane is adhered to the promontory and it won't come out. So it is also known as adhesive otitis media. Okay, tympanic membrane is adherent to the promontory. So these are the four stages of the retraction of the tympanic membrane. Depending upon the stages, it can be severe or mild. Okay, so we have discussed that unsafe CSOM has lots of complications. Now what are the features of the that suggests there is a complication, okay, in unsafe csom. Now we will discuss about this in detail in a different video, but we will just touch on the surface how you can see like there is complication. Okay, so normally when there is uncomplicated csom, we don't see pain. Okay, so pain is a very important point that suggests that there is complication. Okay, and we can also see systemic wise, like if there is vertigo, you can suggest you can just think that there is lateral semicircular canal erosion, and it may be due to complication of the cholesteatoma. Because if you may know if the middle wall, if you can see like that, okay, you can see the lateral semicircular canal here, oval window, round window, okay, and the facial nerve coming through like that. So if the cholesteatoma has eroded the lateral semicircular canal, it will enter into the labyrinth and it will lead to vertigo. Okay, so persistent headache and fever, nausea, vomiting suggest of intracranial infection. Okay, facial weakness again suggests erosion of the facial canal, the fallopian canal in which the facial nerve runs. And irritability and the neck rigidity suggests meningitis. Diplopia suggests peritositis. Sorry. Ataxia suggests labyrinthitis or cerebral abscess, and abscess around the ear suggests mastoiditis. Okay, these are some of the features which suggest complication in CSOM. So how do we manage a patient of CSOM? Unsafe CSOM, sorry. Okay, so what is the treatment of unsafe CSOM? So basically the mainstay of treatment is surgery. Okay, now what are we aiming for when we do surgery? So the primary aim is to remove the disease, and render the ear safe. Okay, although it is important to get the patient hearing and to conserve the hearing and all, but the primary aim is to remove the disease and render the hearing. Okay, and if then we can just reconstruct and we can help and conserve the hearing, then it is very good. Okay, so first let's discuss what are the treatment modalities. Okay, so surgery can be of two types, like there is canal wall up procedure and canal wall down procedure. Now one may say canal wall up and canal wall down. The wall we are talking about is the wall between the mastoid and the middle ear. We're talking about the posterior wall. I have just shaded it here. Okay, this is posterior wall, this wall. Okay, so if in a surgery you are just drilling through this wall and you are just removing this wall and you are converting the mastoid and the middle ear into a common cavity, it is known as canal wall down procedure, because you are removing this wall. Okay, if you are removing this wall like this, is a canal wall down procedure. In canal wall up procedure, we are not interfering with the wall. Okay, and we are proceeding with the surgery through the facial recess. Okay, so canal wall up procedure is known as the facial recess approach or posterotympanotomy. Okay, it is done in case where there is less cholesteatoma in the middle ear and the mastoid. Okay, since there is less cholesteatoma, we can just go through the facial recess and we can just take out the disease part and the patient may still be fine. But since we are walking through a small recess in the posterior wall, there may be chances that some of the cholesteatoma may get left and there's recurrence. Okay, so the chances of recurrence is very much more in canal wall procedure. Okay, canal wall down procedure is done in cases with extensive cholesteatoma, where the cholesteatoma is very large and it can't be taken out through the facial recess. Okay, so let's talk about canal wall down procedure. So first, we give a post auricular incision. Okay, so if this is the ear, okay, and the patient is facing fronts. Okay, now this is the mastoid here and this is the incision that we give here. Okay, it is known as the Willis incision. Okay, then the pinna is retracted forwards and we drill the mastoid in the McEwan's triangle. If you know the anatomy, then you know McEwen's triangle is the bony landmark, okay, where we have to drill. Now then we have to remove the cholesteatoma flakes from the mastoid antrum and from the attic area, okay. Till here, till from the Wildes incision till here, the procedure is common in both the canal wall up and canal wall down procedure, okay, it is same. But from here, whether or not you are removing the wall between the mastoid and the middle ear, it changes the modality, okay. So in the canal wall down procedure, we remove the wall between the mastoid and the middle ear, okay, and then middle ear and the mastoid are converted into a common cavity. Then we remove the diseased part from the middle ear, okay, from the middle ear. So the canal wall down procedure can further be divided into radical mastoidectomy and modified radical mastoidectomy, okay. So in radical mastoidectomy, we remove all of the mucosa and ossicles except for the footplate of stapes, okay. We remove entirety of the middle ear mucosa and ossicles and just leave behind the ossicles of stapes, and the eustachian tube is closed, okay. Now why do we remove entirety of the middle ear mucosa and the ossicles, just leaving this footplate of stapes behind? Why do we just close the eustachian tube? Because earlier we thought that radical mastoidectomy is the best way, okay, and if we remove entirety of the mucosa, there is less chance of recurrence, there is less chance of fistula formation, and there is less chance of any infection coming again, okay. But we don't go for that because sometimes there can be salvageability, okay. There can be conservative things that we can do. We can conserve the hearing, we can just reconstruct. So then we have a new modality that is known as the modified radical mastoidectomy. Here only the unhealthy tissues are removed and there is reconstruction done. So we can reconstruct with tympanoplasty. The ossicular chains are reconstructed, the perforation is reconstructed. If there is any hearing that it can be salvaged, we salvage the hearing. So it is a better modality these days, and we usually prefer modified radical mastoidectomy now, okay. So that's pretty much sums up what we need to know about unsafe CSOM. Thank you.